So I have to admit that it's very difficult to give a talk after Dr. Rowe. And I will talk about some of the novel molecular tracers, but mainly some of them will be like historical tracers, but still worth to mention. So these are my disclosures. So PET imaging of prostate can be done in various ways, and you are seeing the menu of the tracers that you can use in your daily life, and they're all targeting different things, like different metabolic pathways, glucose, fatty acid, or like cell membrane synthesis, or amino acid transport, or like, as Dr. Rowe mentioned, expression of PSMA on the cells. So, as I mentioned, some of these tracers have been reported in the literature, and they are not in use, but it is worth to mention. So, FTG is the most commonly used PET tracer. Its role in prostate cancer is sort of limited, but I think your interaction will be mainly some incidental uptakes that you may see in patients done for other indications. It is not very rare to see such uptakes, and sometimes if you further interrogate them with MRI, you may end up finding cancers. But again, this is not a very reliable tracer to find out prostate cancers, especially at localized phase. This was a paper we published some years ago, and this was a pathway that we did for the incidental uptake based on the SUV max. But again, I really don't recommend you to use FTG for localized disease. C11 acetate was the very first novel tracer we tested out in our clinic. In 2012, we published our results. This is a molecule with a half-life of 20 minutes only. We did a study in localized disease, and as you can see, there's a large lesion here on the right. It shows specific uptake. The whole month shows you a Gleason 8 cancer process. But if you look at those charts carefully, there's a significant uptake overlap between tumor and the BPH. So it locates you with some false positives, so it's not a useful tracer for localized disease. Our next trial was with fluciclovine, FACBC, or Oxymin, and we completed our trial in 2014. Again, I'm going to talk about only localized disease because it's a local prostate cancer meeting. So as you see, there's a lesion here, a cancer lesion, and the FACBC or Oxymin shows the lesion perfectly. But this wasn't the story in all of our cases. Like if you look at these graphs again, there's a huge overlap between the tumor signal and the BPH signal. This is a very good example. We were very excited that this was a cancer area prospectively. However, that ended up to be high-grade PIN. There was only this cancer area, and as you can see, both BPH and the cancer showed uptake. So it is not as strong as PSMA when you want to profile the localized disease. But it is successful in finding out the BCR process. As you can see, there's a lymph node here, and there's a local recurrence which was detected on Oxymin scan. Sodium fluoride has been in use for a long time for bone disease imaging. It is approved by FDA in 1972. And it is usually compared with the technetium bone scans, and it has several advantages, such as having a higher spatial resolution, higher clearance rates. Injection to imaging is about 1 hour compared to 3 to 4 hours, and you can get tomographic imaging with sodium fluoride. So as you can see, the bone scan of this patient doesn't reveal any pathology other than the DJD, but sodium fluoride shows you lesions in hidden locations, upper extremity and pelvis. This was a very dramatical case. We imaged about 10 years ago, 57-year-old African-American PSA 42, very high localized disease, Gleason 9. We did a bone scan, and bone scan was negative, but sodium fluoride revealed a lesion in clivus on the left. They didn't believe in us. We did an MRI, and MRI was showing that this was a metastatic lesion, isolated met, so we saved this patient from unnecessary local intervention. The next molecule I will focus on is this gastrin-releasing peptide receptor targeting. It's a bombesin agent, and it is documented. This molecule has been documented to be overexpressed in several tumor types in human, including prostate cancers. There are two mechanisms that you can utilize to image. You can use an agonist or an antagonist. They did some head-to-head trials. If you do the agonist, then you will end up having lots of GI symptoms in your patients. So mainly the GRP antagonists are used today. Again, the biodistribution is through pancreas and renal excretion, and some papers claim that there is low amount of expression of this GRPR in BPH and inflammation. Here are some samples from the literature. As you can see, like the antagonist is doing a lot better job than the agonist agent, but again, it is not documented to be as successful as the PSMA. Well, last few years was a very exciting period for us for molecular imaging, and several PET tracers targeting PSMA get FDA approval. They have their unique advantages and disadvantages, as you can see. But the good thing is this is all available to our patients in the United States. So a few samples about PSMA. 70-year-old male, PSA 5.2, and there's a lesion here in the right peripheral zone. And we did the PSMA imaging, and it locates the lesion perfectly. And if you realize that the patient has lots of BPH and a patchy peripheral zone on the other side, but PSMA doesn't show any uptake in those areas. So it is a very good candidate to profile your disease burden and maybe guide your focal therapies. This is a 76-year-old male. PSA was very high. PSA density was 0.2, and the MRI was absolutely negative in this patient. And we did a PSMA PET scan, PET CT, and there's a focal uptake here at the right mid base of the gland. The guided biopsy was Gleason 9, so it did better than the MRI in this case. So it is a very powerful tracer, and again, no uptake in the BPH process. So this is the basic menu of the tracers, and you can image your patients with most of them nowadays. And it all depends on what you want to see in the biology of these patients. Some of them has advantages, some of them has disadvantages, but at the end of the day, if you want to profile different biologies, it is all available. Currently, I think the strongest evidence for localized disease and it is staging is PSMA PET CT. And again, we are so lucky. We were one of the first institutions who tried that out. Dr. Rowe, Dr. Pomper, they are our collaborators, and with their significant support and help, we wrote so many articles in that domain. So with that, I would like to thank my colleagues again from NCI and outside NCI, and thank you for giving me the chance to share my experience about novel tracers.